Get online. Hi, everybody. Thanks for joining us today on another CU session. Today, Namrata is presenting living systematic reviews and a network meta-analysis. It's a fairly complex topic, and kudos to Namrata for taking this leap. All right, handing over to Namrata.
Thank you, ma'am. Good morning. I am presenting today a living systematic review and meta-analysis and the critical appraisal of the same. So our learning objectives for today are to understand what a living systematic review and a network meta-analysis is. I'll be abbreviating this as LSR and NMA respectively, and to understand why they are performed, to learn how to interpret their outputs, and to identify common biases and pitfalls. And finally, we will critically appraise a living systematic review and NMA and judge whether its conclusions are trustworthy and applicable. So first we will understand the structure of an LSR and NMA, and then we will critically appraise an article that involves this. So the first part is understanding this, a living systematic review and network meta-analysis. So I'll start with a clinical scenario. So there's a 35-year-old man who comes to our OPD. He was admitted post a knee surgery for osteoarthritis knee with a pulmonary thromboembolism, treated for the same, recovered and come back to OPD. He's morbidly obese with a BMI of 40 kg per meter square, and also has early onset type 2 diabetes, young onset hypertension, dyslipidemia and obesity hypoventilation syndrome. He has tried many diets with little benefit, and he is wondering if there are any pharmacological methods to lose weight. So why we need living systematic reviews in this kind of context is because the evidence is a lot. There are many trials, many interventions, rapidly changing evidence, and traditional systematic reviews have now become outdated because we need to keep updating our evidence as trials are updated online. Network meta-analysis is a mathematical way to combine all available treatments and helps us to use direct evidence that we have and draw indirect evidential conclusions from this. So while we were discussing obesity, this is just the pipeline, drugs that are in the pipeline for obesity. This is the reason why living systematic reviews and network meta-analysis are so important, because right now we have semaglutide, tirzepatide, orforglipin, retaglutide, all these things that we know about, and these are just the drugs that are in phase 3 or in the market. In another 2 years, all of this will enter phase 3, and many of these will go into the market as well and enter phase 4 post-marketing surveillance. So if we were just to do a systematic review on phase 3 within a year, this would be outdated. So this is the need for living systematic reviews. Obesity affects 1 in 8 people globally, and the WHO guideline recently says that there are 44% of all adults are obese or overweight. The obesity market is huge, bringing in revenues of billions of dollars. The top 2 drugs being semaglutide and tirzepatide. Together they have generated about 13 billion US dollars in revenue over the year, and this is expected to triple in the next 4 years. So living systematic reviews and network meta-analysis help us to make wise choices about new and expensive drugs and help us to compare them to existing standards of care. Now, this is the commonly put up hierarchy of evidence. So I've put LSRs and NMAs up there because they are an updated form of a systematic review and a larger form of a meta-analysis. One thing to note when we are looking at this hierarchy is this is arranged by robustness of trial design. But an important concept is a well-done cohort can actually answer a question better than a poorly done RCT, depending on what your question is and how rigorous the methodology is. So presuming that methodologies are rigorous, this is the order that it follows. Now the prerequisites to conduct a living systematic review are there needs to be a pre-specified protocol for a regular literature surveillance and an update schedule. And there should be incorporation of new evidence statistically, and conclusions might change over time as and when new evidence is incorporated with the old. So what is the basic concept of a network meta-analysis? So this is basically from a cartoon I like. So basically if we know that the bunny is shorter than the fox and the man is taller than the fox, then obviously the man becomes taller than the bunny. This is a simple way to understand direct and indirect evidence. If you know A versus B and B versus C, then maybe you can draw a conclusion on A versus C. So, taking our example, we have trials that compare semaglutide and lifestyle. We have trials that compare tirzepatide and lifestyle. So, if you had, there is an RCT that compares semaglutide with lifestyle, and the odds ratio of semaglutide versus lifestyle is 0.94. There is another RCT that compares tirzepatide to lifestyle, and the odds ratio for that for all-cause mortality at 5 years is 0.67. Now, we don't have any RCT that informs tirzepatide versus semaglutide. This is just a hypothetical example. So, we are able to mathematically calculate from these two arms an indirect odds ratio, which will come out to be 1.44. Now, the good thing about a meta-analysis is, a network meta-analysis is, say you had, now I'm going to add another arm here, which is phentermine topiramate, which is another anti-epileptic and appetite suppressant drug that is used for obesity. Suppose you had a trial that compared tirzepatide and phentermine topiramate. You could get an odds ratio from the direct evidence. Then, because you have this arm, which is tirzepatide versus lifestyle, and you have this arm, which is phentermine versus lifestyle, you can calculate an indirect odds ratio as well. And you can combine these two to make a mixed odds ratio. Now, what is the advantage of doing this is, your sample size becomes so much more. You have, when you have direct and indirect evidence, you have a larger sample size to inform your treatment estimate, and thereby a narrower confidence interval. Now, networks are often not as simple. Networks can look like this also. Many times, some arms in the network are not connected to anything other than one node of the network. So, look at this example where A, B and D are connected. A, C and D are connected, and C is connected only to E. Now, the concept I want to say in this is that, you know, maybe it's better if I draw this. Sorry, just give me a second. I want to use the pen. Okay, never mind. Yeah. So, the concept I wanted to bring about here is, we have a comparison between A and C, and we have a comparison between C and E, right? So, A and E would be the indirect treatment estimate that you get from this triangle. But an actual network meta-analysis doesn't use this arm alone. It will also combine evidence from A versus D indirect comparison, D versus E indirect comparison, and use it to inform the A versus E indirect comparison. So, what I'm trying to say is, if we have a network meta-analysis, we can't just calculate based on two arms. The information for an indirect estimate from a network analysis, meta-analysis is from all the arms of the network meta-analysis, and it is calculated using a software. We can't manually derive this. All direct and indirect estimates in the network meta-analysis will contribute to a direct arm, even if E is not linked to anything else. Now, in our comparison that we took earlier, the odds ratio from the direct meta-analysis represented by blue is 0.67, the indirect was 0.81, and the OR comes to be 0.71. So, if this were an answer as to how much this reduces mortality, that is, how much does tirzepatide reduce mortality compared to phentermine topiramate, this will give you a very optimistic result, the direct network meta-analysis, the direct analysis. The indirect analysis will give you a more pessimistic estimate, and the odds ratio will be somewhere in between. with a narrow confidence interval and a more higher degree of certainty in the final estimate. Next, we are coming to the concept of how a network diagram is drawn. So, how a network diagram is drawn is, these round circular things are called nodes. So, the node, the size of the node represents the number of participants. For example, almost all the participants, almost all the studies in this network meta-analysis had a placebo plus or minus a lifestyle arm. The lines that connect nodes are called edges, and the thickness of this line says how many studies are there, how many RCTs are there comparing these two. For example, there are 14 RCTs comparing placebo or lifestyle to liraglutide, whereas there are only 2 RCTs that compare liraglutide to semaglutide. There are 18 that compare semaglutide to placebo and lifestyle. So, again, the size of the node represents how many participants, and the thickness of the edge represents how many studies are there in that pairwise comparison. There is a concept called node splitting and node merging. Node splitting means, suppose we say topiramate at doses 12.5, 25 and 50 are 3 different interventions. Then that's called splitting of a node. This is up to the clinician and the researcher to decide. Whereas if we say that for the purpose of a network meta-analysis, all doses of topiramate are considered as a single node, then we would put all that together, and that is called node merging. Sometimes we would even say all the drugs in a particular class are of the same node. So all GLP-1 agonists are grouped together to form one node. Now these are 2 important principles of NMA that we are coming to. The first one is called transitivity, and the second one is called consistency or coherence. So transitivity means, are the 2, when we are comparing A versus B and B versus C, and we want to get an estimate on A versus C, the studies that compare A versus B and B versus C should be very similar. For example, if one study had an intensive meal replacement therapy along as a placebo, and the other study had just counseling once in a while as a placebo, then it will affect the estimate of A versus B and B versus C. So the basic principle is, we can't compare apples to oranges. Both your studies that you are comparing, the direct estimate should be similar enough, the studies that inform your direct estimate should be similar enough to draw an indirect estimate from them. That is the principle of transitivity. The next principle is coherence or consistency. So coherence means, I'm just going to go back to my prior example. So the direct evidence and the indirect evidence both said that tirzepatide is better than phentermine topiramate. However, if our indirect odds ratio was say 1.8, your direct evidence is saying tirzepatide is better, your indirect evidence is saying the complete opposite. So it's incoherent. There is something wrong, either something wrong with the studies that did the direct evidence, or something wrong in the calculation of the indirect estimate. So this is called incoherence. Both of these, both transitivity and coherence have to be fulfilled for a successful network meta-analysis to be calculated. So the analogy I took here is Chinese whisper, right? So when someone tells a secret and the other person has to pass on the secret, if this person, the first person relays the secret properly, is when the second person can pass on that information. And the information that this third person gets is only as good as the first and second person's information. The last concept I am coming to before we go into the critical appraisal is something called SUCRA. SUCRA is surface under cumulative ranking curve. I'm not going into the depths of this. This is basically a way in which after you do the network meta-analysis, you can rank your outcomes. So very often when we are choosing treatments for patients in OPD, we just want to know what is the best, right? So the alternative option is you are looking for a particular drug versus a particular drug, but very often we look at what is the best outcome. So SUCRA is a way to understand that. It basically gives you on the right corner you can see the SUCRA values. A value above 75% means this drug has a high probability of being ranked the best. That's all. It doesn't mean that it is the best. So what we have learned so far is what a living systematic review is, and what indirect and direct estimates in a network meta-analysis are, and what are nodes, edges, what is transitivity, coherence, and what is SUCRA. Does anyone have any doubts at this point? Okay, then we will go on to the critical appraisal of a living systematic review and network meta-analysis. So the same scenario, a young obese gentleman who has a lot of complications related to obesity as well as morbid obesity, who has tried lifestyle intervention and wondering whether there are pharmacological methods. So the systematic review that I looked at to answer my question was this one: benefits and harms of pharmacological treatments for adults with overweight or obesity. This was done across, they've taken RCTs from across the world, but what was published in the Annals of Internal Medicine on 16 June 2026. They included 69 randomized control trials that compared pharmacological treatments for weight management. So they had a total of 1,12,511 participants, and the primary funding source was ACP. So the key questions they looked at were effectiveness and comparative effectiveness and harms, patient value and preferences through a quality of life questionnaire, and cost effectiveness. This cost effectiveness bit I am not discussing today because there is a separate review which we will come to next week. So I have used multiple tools to appraise this. So for the systematic review part, I looked at CASP, and then I have added some considerations for a living systematic review, and I have also looked at grade and Cochrane documents for appraisal of the NMA part of it. So we will get into the systematic review part of it. So first we look at whether the basic design is valid for a systematic review. So did they answer a clearly formulated research question? Yes, they did. So they looked at adults with a BMI of more than 25, which was overweight by Western standards. They have also looked at Asians with a BMI more than 24, equal to or more than 24. Interventions they looked at are all of these: dulaglutide, exenatide. I won't read them out, but they are all GLP-1 agonists mostly. Then there is naltrexone, there is fentramate, which is an appetite suppressant, and topiramate, which is an anti-epileptic drug. And tirzepatide is the new kid on the block. It is a combined GLP-1 agonist and a GIP-1 agonist. The comparators are any of the above, or just lifestyle interventions, or prior bariatric surgery procedures. Outcomes were all-cause mortality, major adverse cardiovascular events, severity of diabetes, health-related quality of life outcomes, weight loss as a percentage of body weight, weight regain, serious adverse events, discontinuation due to adverse events, and specific harms. So one driving principle before we design a systematic review and network meta-analysis is all the participants that you are taking should be equally eligible to receive any of the interventions. This is the same principle that guides randomized control trials also. The reason being, if you had somebody who was not eligible to take semaglutide and you are using that for indirect comparisons on semaglutide, you will have a falsely inflated sample size, but actually that participant group is not eligible for the drug. So you will get an imprecise indirect estimate. So for instance, a patient with obesity here should be able to receive anything. So did the researchers search for an appropriate study design to answer the research question? So because efficacy was the main question they were answering, they have taken only RCTs. Next we are looking at section B, is it methodologically sound? So were all the relevant primary research studies likely to have been included? Yes, they had a thorough search strategy. They searched Medline and Central and looked at all trials from inception until 10th October 2025. And they also looked at ongoing trials from the WHO Clinical Trials Registry Program and clinicaltrials.gov. They included only trials in English language, and they included solely Asian populations also with a lower BMI cutoff than what they had pre-specified. They also have a table in the appendix with the mesh terms that they use. Mesh is the terms that they use to search on PubMed. So there is a search strategy. The idea of giving this in a systematic review is if we can cross-check that search strategy. There are ways in which a search strategy is written. It's like computer code, sort of, in an easier way. But when we check it, we should be also able to get the same studies. So that is the reason why these mesh terms should be provided. Two reviewers independently screened all the titles and abstracts, and subsequently they used EPI reviewer to screen the full text and then disagreements were resolved by discussion with the third reviewer. For inclusion, they looked at any adult who was overweight or obese with or without comorbidities. Exclusions that they had were previous bariatric surgery, ongoing weight loss program, and use of antidepressants, insulin, or other medications that can cause weight loss or weight gain. Now, one thing that I found very positive was that they had very detailed tables as to why studies were included, why studies were excluded. So, before we go into that, I am just showing the Prisma flow diagram. So, they had about 4,000 studies that they identified. They removed records because of duplication. They removed some ineligible records, had 2,438 left, excluded another 2,047. Here, they have not given the reasons for exclusion. Then they retrieved 391, and they have given reasons for why some of them were not retrieved also. They were not in English, they were duplicates, they were abstracts of conferences, full texts were not available. Then finally, they assessed for eligibility 285 articles. Out of which another 187 again they excluded. Now this 187 they have fully written in the supplementary analysis why they have excluded. Most of them were excluded because of the study type not being an RCT, or there was a post hoc analysis that was done that informed the primary estimate. Finally, they included in the review only 69 RCTs. Also, they did what we are supposed to do in all systematic reviews. They went through the references of all the articles and assessed another 11 articles for eligibility. So, did they assess the validity or methodological rigor of the primary research articles? Yes, they did. So, they used the Cochrane ROB tool to assess each RCT separately. And again, this was verified by a second reviewer and a third reviewer, and disagreements were verified by a review author. So, this is all the 69 studies that they included. So, the green says that there is low risk of bias. So, for those who are not familiar with the Cochrane risk of bias, there is a domain which looks at blinding, there is a domain which looks at methodological rigor, there is a domain which looks at missing or loss to follow up, there is a domain which looks at how the outcome is measured, and there is a domain that looks at whether the results were reported selectively. So, all five, so each RCT you have to take all the information out and look, was it blinded properly, was it done properly, were the results reported properly, did they selectively report some results, was there missing. So, this is a mammoth task for 69 RCTs, like, you know, we present one RCT on every journal club. People have to do this for all of these articles. And finally, they will come up with an overall risk of bias, which is on the right side in the grey shaded column. So, red says high risk of bias, yellow says some bias, and green says low risk of bias. Why this is important to do is, when we are doing so much complicated mathematical derivations for a network meta-analysis, you should remember that your answer is only as good as what you are putting in, right. So, if you have not so great studies that are informing the network meta-analysis, your result is not reliable. So, after doing all this process, you will have to say that the studies I included were doubtful. This is why you should do this at the get-go. Now, this is the overall risk of bias rating. So, overall out of the 69, there were 37 studies with low risk of bias, and there were about 11 with high risk of bias and 21 with some concerns regarding bias. Frequent reasons for high risk of bias were exclusion of participants with missing data and high number of discontinuations, especially when they are unbalanced between both the arms. Now, did the researchers extract and present information from individual primary research articles appropriately and transparently? So, one reviewer extracted everything. This was all verified by second reviewer and third reviewer, and they used EPI reviewer. So, this is how they have shown their data, and this is there for all the included studies, and then for the excluded studies they have separate tables that are saying why they are excluded. So, they have the pie chart of all the included studies. For example, this Ahman et al. In 2018, they had adults with type 2 diabetes. The comparators were semaglutide versus exenatide, and there was no lifestyle intervention used, and the outcome was weight loss, and the follow-up duration was 56 weeks. I just wanted to bring to everyone's attention that in this systematic review, their minimum period for taking studies was 52 weeks. They needed at least a 52-week follow-up because all-cause mortality and MACE were outcomes that they were looking at. They also had for each study the inclusion criteria, exclusion criteria and baseline characteristics. So this was very well done, I thought, like it was there for all 69. My critique on this part before we go into understanding the results of the network meta-analysis is actually they have not given, they have said it is a living systematic review, but there is no details as to when they are going to update it, which is the primary thing of a living systematic review. You have to give details as to when you are planning to update your information. I also looked at the Prospero protocol, but I couldn't get the entire protocol. Whatever I could get, it was not there. Details on optimal information size are not available. So optimal information size is the systematic review analog of a sample size for an RCT. So it's not necessary that you do an optimal information size, but grade for systematic reviews actually recommends that you pre-specify this, so that if it is not specified, then you downgrade for certainty of evidence. Ideally, in a living systematic review, there is a methodology called trial sequential analysis that you have to use for alpha error inflation. So basically what happens in a living systematic review is, if you keep adding trials, your alpha will get inflated. For example, if you are tossing a coin 10 times and 8 times you get heads, at that point if you think, oh, is there something wrong, it's too late into the process, right? So at every point you have to check your alpha in a living systematic review and you have to adjust. There are various alpha adjustment techniques. What will happen is, if you only take 5% alpha and keep adding studies, then the actual alpha will be much more than 5% and you have a high chance of getting a false positive result. So trial sequential analysis is a way in which you adjust for alpha error inflation as you add new studies. So the summary slide of what we have learned so far is how we search for articles for a systematic review and how data is extracted for a systematic review. And there are few points on differences between a living systematic review and a systematic review in terms of methodology. Now, section C, are the results of the systematic review trustworthy? So, did the researchers analyze the pooled results of the individual primary research studies appropriately? So, yes, they did. One thing was they didn't mention the optimal information size. I will come to a few of the results first before continuing with the appraisal. So again, we saw what the nodes, nodes are the circular things in a network meta-analysis, right? So those are the interventions. So these are all the interventions they were looking at. So there were 25 studies that had semaglutide as an intervention, there were 22 that had liraglutide, there were 10 that had tirzepatide and so on. The outcomes that they looked at, we already saw: all-cause mortality, MACE, change in HbA1c, weight loss, health-related QOL, weight regain, adverse effects. Now, before we look at the evidence generated by a NMA, we have to do three things. First, we have to assess the quality of the direct evidence. Like I said, your result from the NMA is only as good as the studies that informed them. So first you have to look at the quality of the direct evidence. How certain can we be about the estimates that the direct evidence is giving us? So first we use grade, and then we have to make all the direct comparisons via a forest plot. Then we look at heterogeneity among the studies. And finally we look at the NMA assumptions, whether they are fulfilled or not, that is transivity and coherence. So when we are trying to understand what grade is a way to understand how certain are you about what you are saying. It is not an assessment of the RCT's rigor, that is ROB. So one part of grade is ROB. For example, in this cartoon, this woman is saying, I figure there is a 40% chance of sunny weather. That is your treatment estimate, correct? 40% is what is the chance of sun today. But she has only a 10% knowledge of what she is saying. Yeah, so there is only 10%, she only knows what she, so this 40% is not true, right? She probably, 90% of the time she is wrong. So this is what grade does actually. So this is the basic grade table. So randomized trials start off high, observational studies start off low. You can downgrade a randomized trial, you can upgrade an observational trial. So there are 5 components in grade. So risk of bias is that green and red and yellow thing that we saw. Then there is inconsistency, there is indirectness, there is imprecision, and there is publication bias. Each of this answers different questions about the entire systematic, the body of evidence that is there in your systematic review. One important thing to note is grade is done for each outcome. For example, there is a grade for all the studies that are informing mortality. There is a grade for all the studies that inform HbA1c change. There is a separate grade for all the studies that are informing weight loss, right? Now, after you find out how certain the evidence from these direct estimates are, you look at whether they are heterogeneous or not. So, one way, simply when we look at a forest plot, that I square, tau square and all gives us an estimate of the heterogeneity of the studies that are informing that particular outcome. Now, these authors, they have multiple forest plots. For want of time, I have not put up everything, but they did not find any consistent evidence that these were very heterogeneous. So, they pooled a lot of the interventions together to make one node. For example, all the doses of semaglutide were pooled together. Oral and IV semaglutide were pooled together. I don't fully agree with this because there is a problem of adverse events. Adverse events are dose dependent. But anyway, in this study they have done this. So they have the way in which they find out whether there is heterogeneity or not is the methods are meta-regression and subgroup analysis. Now, when you say, so I said that transitivity is like comparing apples and oranges, right? So, for example, if I eat a green apple and a red apple, and I say a pink apple tastes somewhere in between these two. It's not as sour as a green apple, but it's not as sweet as a red apple. That is transitivity, right? So, when studies are similar enough, you can say that there was no evidence against transitivity, but it doesn't prove transitivity. You can assume that transitivity is there. But if the studies are all very different, you can definitely say that transitivity is lost. Now, these authors have also given these box plots to look at the transitivity assumption. So, for example, this is called an effect modifier. They feel that age can change your all-cause mortality. So, actually they have gone back and looked at all the ages in these studies, and they have plotted the age as a median and an interquartile range. This is called a box plot. So, what we can say is, across all these studies, everyone's age is somewhere between 50 and 60, most of the people. Now, if there were very young people and very old people across the different studies, you could say that they are not similar enough to be compared. So, this is one way in which you can visually represent transitivity. Okay, now this is the forest plot for all-cause mortality. I won't dwell too much on this. I just put this so that there are concepts of the forest plot that are covered for those who are new to it. So, how a forest plot goes is the intervention and control is given, and all the studies that looked at that is given. Now, one second. Okay. So, what is extra in this forest plot is actually they have given some of the baseline characteristics of the population also. This is to make it easier when we are reading the network meta-analysis, but traditional forest plots don't contain this bit. And then you are looking at the intervention versus the comparator. So, how the N is the number of participants and E is the number of events, right? So, normally forest plots will give you like a relative risk of the intervention the treatment effect in the intervention arm versus the treatment effect in the comparator arm. And then there is an odds ratio for the entire thing. So, the line shows the range of the odds ratio, and the circle shows the average treatment estimate. Now, in a forest plot, normal forest plot, the sizes of these will also vary. I'm not sure why they didn't, because there are variations in sample size a lot. I don't know why they didn't change the size in this forest plot, but normally the sizes of these are proportional to the number of participants participating. and then this diamond is the average treatment estimate. Okay. So one important thing to look here is the scale. Because we are looking at odds ratio, the line of no effect is 1. Okay. So if you have, if your odds ratio is 1, that means there is absolutely no difference between the intervention and the comparator. It's also supposed to tell you which direction favors the intervention. So for mortality, if your mortality is lower, that means it favors the intervention. If your mortality is higher, it favors the comparator. But note here that the scales are very different. So mortality scale is like 0.05 and the same thing for comparator is like 64. Okay, coming back to our network meta-analysis, I wanted to introduce the concept of a closed loop versus an open loop here. So just look at this loop, which is placebo, semaglutide and liraglutide. This is a closed triangle. This is called a closed loop. You know, the effect of a closed loop is that you have direct evidence for all the 3 arms and you can calculate indirect evidence for all the 3 arms. And then you can do what I mentioned earlier. You can check whether it's coherent or not. You can check whether your direct and indirect treatment effect are in the same direction. If it is, you are sure that there is coherency in this loop. But when you have an open loop, you can't do that. For example, look at this loop, naltrexone, bupropion, placebo and lifestyle, semaglutide and say tirzepatide. This is an open loop, right? So when, or an easier open loop to look at will be A, B and C. This is not connected. So there is no A versus C trial. So the A versus C can only be estimated indirectly. So when you do that, you cannot test consistency for or coherence for A versus C, because you don't have a direct treatment. You don't have anything to compare the indirect treatment estimate to. But in real life meta-analysis, network meta-analysis, we accept this. We accept some amount, because in truth, most drug companies, which are the ones that fund these trials, will not pitch their drug against another drug. They will always pitch it against placebo or lifestyle intervention, right? Okay, now this is the network meta-analysis plot for serious adverse events. Same thing, I just wanted to recap these concepts. Node size, edge size. So node size is number of participants, edge size is number of randomized trials that are in this pairwise comparison, and then closed and open loops again. Now in incoherence itself, there is local incoherence and global incoherence. Local incoherence is, like I said, we are just looking at one loop in the entire network meta-analysis. Global incoherence looks at the entire network meta-analysis and tells you that there is some inconsistency somewhere, but we don't know from which loop, we don't know which loop it comes from. Okay, so we have finished the bit about understanding how a network diagram is drawn. Now, when we are, like I said, for a systematic review and meta-analysis, the core principle is that we have to assess how good the evidence is before we make our mathematical conclusions from the same evidence, right? So, there is a BMJ paper by Gordon Guyette from McMaster University in 2023, and he has actually proposed that we do grade for direct estimates separately, indirect estimates separately, and then the mixed estimates separately. This is a colossal task, but like when we do it, we can say with certainty or low certainty or moderate certainty about whether we can trust our effect estimates or not. So this is just a flow chart of how you go about it. So basically, I had shown the grade for direct evidence, right? So it's risk of bias, inconsistency, indirectness, publication bias and imprecision. You have to run through all of this for all the direct evidence that you have. Then you at least have to do ROB, inconsistency, indirectness and publication bias for the indirect evidence that you have before you come to making mixed estimates from the indirect and direct evidence together. These are two other tools that we came across, ROBIS and ROB NMA. So, I don't want to get too much into this because we will deviate a lot from our original topic, but basically this is how you assess at a systematic review level and a network meta-analysis review level about the certainty of your estimate. what I said, grade is for the systematic review level and ROB is for the RCT level. These are two other tools that you can use to assess certainty for systematic review, that is ROBIS, and ROB NMA for the network meta-analysis. So like I said, they have done grade for direct evidence, and then there is so this is the certainty of evidence, right? So wherever information is available, they are able to tell you a certainty of evidence. Again, for the indirect evidence, so we can run, mathematically using software, whether you can run endless numbers of loops of indirect evidence. The question is it worth running it or not, right? So that's why we should do certainty of evidence for indirect estimates as well. So like this, the authors have given for each drug comparison. So like cagrilintide and dulaglutide, there is if there was no study to inform, K is the number of studies, N is the number of participants. There was no study to inform a direct estimate. But somewhere else, using some other study, they could make an indirect estimate. And then they did this uncertainty of evidence for the indirect estimate. Similarly, for each treatment arm, they have done this. For direct, indirect and the mixed treatment, they have looked at the certainty of evidence. Now, cinema is confidence in network meta-analysis. So basically, it is an analogy of doing grade for a network meta-analysis. The authors here haven't used it, but it is a tool that can be used. So the summary of what we have learned so far is direct evidence needs to be rigorously evaluated for the certainty of evidence via grade. And there are other tools also that help to evaluate risk of bias alone. We saw the ROBIS and the ROB NMA. That is only for risk of bias for at the systematic level and systematic review and network meta-analysis level. We looked again at transitivity and incoherence and open and closed loops and cinema. So we are now coming to the results of the study. So this is the summary of findings table. Okay, so on top, very important is the authors have mentioned what is a meaningful effect threshold for them. This is very important because mathematically significant results might not always be clinically significant, right? So for each outcome, that is for all-cause mortality, they have said the minimum it should reduce mortality is 0.8. So if you have a treatment estimate that crosses 0.8, say it's 0.9, then it is not important. Similarly, now I am specifically going to look at, okay, so this is the legend. 3 crosses are high certainty. So certainty again we rank using grade. 3 crosses are high certainty, moderate certainty is 2, low certainty is 1, and if there is insufficient evidence, it is not given at all. Sometimes comparisons are informed only by indirect evidence. Sometimes they are, but most of the time where they have direct evidence, they have tried to make mixed effects for all the comparisons. So because we are looking specifically at my question was semaglutide versus tirzepatide, so I have only put up the tables for those. So I am comparing semaglutide to placebo here, okay. So this is for all-cause mortality, MACE, severity of diabetes in those without diabetes, severity of HbA1c in those with diabetes, quality of life, percentage of weight loss. So I am not going to look at all of these, probably we will just look at all-cause mortality and MACE and percentage body weight loss. So in all-cause mortality, it said that semaglutide had an OR of 0.81, odds ratio of 0.81 with a confidence interval of 0.71 to 0.91. Remember that I said that the minimally important difference was 0.8. If it has crossed that, if the confidence interval has crossed that, this is not significant. So that's why it's not highlighted. It's a not significant result. Similarly, like that, for our 10% body weight loss, it actually crossed the line of significance. So this was, and they had a lot of evidence and a high certainty of evidence. So that's why it's given in dark green. there was also some effect on a reduction of HbA1c in populations with diabetes when you compared semaglutide to placebo or lifestyle. Same thing I have done for tirzepatide. The upper part is a continuation of the prior table. This is the upper row is semaglutide versus tirzepatide. So actually there they found that semaglutide was worse than tirzepatide in achieving body weight loss. Now tirzepatide versus placebo for the same outcomes of all-cause mortality, MACE and percentage of body weight loss. Again, for all-cause mortality and MACE, there was no significant, actually there was no information itself, there was insufficient information to inform this estimate. But they found that when you compared tirzepatide to placebo or lifestyle, there was a significant weight loss with a large effect and moderate certainty of evidence. The same table, when you summarize like this, is called a league table. So a league table is basically, so this is column versus row. That's important to look at when you are in a league table, because your odds ratio will ulta otherwise. So this is cagrilintide versus dulaglutide. This is dulaglutide versus exenatide is here, cagrilintide versus exenatide is here. Cagrilintide versus liraglutide is here, dulaglutide versus liraglutide is here, exenatide versus liraglutide is here. So throughout this league table, for all-cause mortality, there was no big significant finding for any of the drugs versus the other drugs. But one important thing to note here is many of these are indirect estimates, because there was no information for drug versus drug. So it has to be interpreted with caution. So did the researchers analyze the pooled results of the individual primary research studies appropriately? Yes, they did. So the effect measures they used were odds ratios, relative risks and standardized mean difference. Standardized mean difference is a way of, when you have questionnaires, you can, it was for the health quality of life questionnaire. When you have questionnaires, you can, when they are on different scales, the effect is expressed as a standardized mean difference. Confidence intervals were provided, p-values were not reported, but in an NMA anyway we don't focus on p-values, we look at the magnitude of effect, precision and certainty of evidence. I-square was reported, heterogeneity was assessed, and they used a random effects model for all the direct pairwise comparisons. So the summary of results from all these tables were that there was no large difference in all-cause mortality or MACE for any of the indirect comparison of drug versus drug. But one thing to note is their indirect comparison. Second thing to note is their period of follow-up was, it's not 4.5 years, it's actually 5.4 years. It is a good period to follow up, but probably not enough for MACE and cardiovascular outcomes. In adults with diabetes, cagrilintide, semaglutide and tirzepatide improved HbA1c compared to placebo or lifestyle interventions with high certainty. Quality of life was better for those treated with tirzepatide, and in adults with diabetes, sorry, this is the same thing as the prior. Now our specific question was to look at body weight loss for our clinical scenario, right? So in all 62 studies, 60,999 participants, any intervention was better than lifestyle or placebo for weight loss. This is only for weight loss, okay? So cagrilintide, semaglutide and semaglutide resulted in weight loss compared to placebo or lifestyle with high certainty. Liraglutide and tirzepatide with moderate certainty, and cagrilintide, semaglutide was better than semaglutide alone in adults without diabetes, and tirzepatide was better than semaglutide in adults with diabetes. So basically any drug, any of these drugs will cause weight loss alone if you use them in adults with obesity, with or without diabetes. Adverse events and harms. Serious adverse events were reported in 55 studies with an N of 1896. There was no important difference between semaglutide and placebo or lifestyle intervention. There was a slightly increased risk for gallstones with liraglutide. No evidence of differences in pancreatitis, which are the two major worries when we are using GLP-1 agonists. Now, discontinuations due to adverse events, almost everyone who was taking some drug discontinued due to adverse events. These are all minor adverse events like nausea, vomiting, bloating, postprandial distress, etc. But definitely there were significant discontinuations for cagrilintide, semaglutide, naltrexone, bupropion, liraglutide, orforglipron, tirzepatide, everything there was some discontinuation compared to placebo or lifestyle. Did they report limitations? Yes, they did. Magnitudes, so this magnitude of minimal effect, no, the 0.8 that we said for on mortality, that was not based on prior studies, that was based on ACP's expert consensus guideline. So that was one limitation. They did not include studies prescribing Orlistat and SGLT2I, which are actually not FDA approved drugs for weight loss, but we still used in practice. The minimum time to follow up was 1 year. So actually studies that looked at weight loss doesn't require 1 year to happen, right? So there were many big studies that were excluded because the period of follow up was less than 52 weeks. And then one problem that I had was they combined different dosages of drugs into one node. So especially for adverse events assessment, this was a problem. Are they relevant locally? Yes, they can, the results of the systematic review can be applied to your local population. I felt like because they had taken Asians and Asian BMI cutoffs also, and because this is a prevalent problem in India, but accessibility to these drugs is an issue in India. So can it be used to support evidence-based decision making? Yes, we can use this trial. So I just did a rough costing. So oral semaglutide for 1 year comes to 2,73,000 in our pharmacy. The absolute, the NNT is actually very high, it's very low, it's 2. But would I spend 2,73,000 for an obese patient for this benefit? I would probably because like if you, his osteoarthritis knee is 1 hospital admission, 1 surgical cost, pulmonary thromboembolism is 1 hospital admission. These two itself would have crossed 2 lakhs probably with ICU and all. He has diabetes, hypertension, dyslipidemia, obesity, hypoventilation, so high chance of developing a major cardiovascular event as well. So overall, I would say I would take for this patient, I would take the weight loss benefit that semaglutide offers with the higher costs for the benefits that it would offer him. These are my references. And I can take any questions.